Hi guys, it's Dr. Eric Lindquist, CEO and founder of SonoPath.com, and I'd like to invite you to pass through your surgical or commuting day in veterinary medicine by listening to our podcast. Real talk in veterinary medicine from experienced professionals who aren't afraid to tell you how things really are so you can optimize your veterinary career and your process. Hello everybody, welcome once again to SonoPath's monthly SonoTalks, real talk and real veterinary medicine. We're here with the new president of SonoPath, Dr. Kenneth Leal, and two of our rock star technicians, Diane McFadden and Shari Reffi. And we're here to talk about the journey of the veterinary technician in clinical sonography, and our publication in VetRad and Ultrasound in January 2021 or 22 was it? 21, yeah, that's been a while. Yeah. Demonstrated that there was no statistical difference between image acquisition from boarded specialist radiologists and others to GPs to veterinary technicians that have been properly trained. So we're very proud of that study, and you're welcome to take a look at that. It was a double-blinded study, and it was something we've been wanting to do for a long time, because those of us in the telemedicine and ultrasound industry know how talented veterinary technicians are and can be in clinical sonography as far as image acquisition goes. And so we wanted to bring Diane and Shari into SonoTalks and have them talk, some real talk about their journeys and challenges from being a veterinary technician in general practice, which both of them have done for many, many years, and then their transition over to clinical sonography and image acquisition and education, because they're both certified SDEP instructors as well. So if you come to one of our labs, either directly on-site or virtually or in your practice, you may be running into Diane or Shari as your instructor. And so we wanted to bring that out into veterinary medicine, some real talk from Diane and Shari. And Ken, how you guys doing today?
Doing great.
Everybody good?
Yeah.
Everybody good? You ready for some real talk? Can you tell us the real talk and how things are in veterinary medicine from a technician perspective? No names. We already established no names. But so Diane, we'll start with you. Tell us about your journey real quick and a quick summary on before you had the ultrasound probe in hand and after, and tell us how things have gone for you.
Yeah, well, I started back in 1986, my first job in a clinic. Started out at reception, worked there for like a year, and I didn't even know that I wanted the job. I just walked in with a stray cat and kind of got rooked into, hey, you want to give us a resume? I said, oh, yeah, okay. And I'd probably, hired them maybe the next day. Guess they really needed people. But anyway, I worked from there. It was very, very small practice, very early stages in the business. So it was nice to, over the next, 17, 18 years, to help them grow from almost nothing to really, really thriving practice. And I worked my way up to assistant and then technician. And while I was there, I went to tech school and got certified. And then that was down in North Carolina. I moved up here and got a job as a practice manager in a local clinic, and which was great. So I had tech work as well as I was practice manager. So I'd kind of been through everything, and over that period of almost 30 years, you got to always keep improving yourself and changing. So I ended up wanting something different, and when Dr. Lindquist was coming into our practice to do our ultrasounds, I just started talking to him about working for SonoPath. And at that point he said, ask me in a year. So I did, exactly 1 year later. And then
you probably had it on the calendar knowing you.
Yeah, exactly this month and day. In September 2015, I started with SonoPath. So it took me to a whole other level, and it's just a wide open area for technicians.
Yeah, you were one of the groundbreaking technicians in veterinary medicine in 2015. I know of a few technicians that made that transition, in 2008, 2010, 2000, but they were very few and far between. So at least up in this area, you broke the mold. So, which is great. So Shari, tell us about you.
So I've been in general practice, or was in general practice for over 25 years, and originally went to school for exercise science. And I grew up with animals. They were, I think I had a really good upbringing, with with the human-animal bond, so I just fell right into veterinary medicine, had horses, and we were always doing stuff, on our horses. So, just fell in love with veterinary medicine, and I always loved imaging. I had a lot of great mentors along the way, for sure. Not naming any names, but you know who you are, I'm sure. But I always loved imaging, taking x-rays and all that. I've always felt if I were to switch over to human medicine, I would have certainly, gone that direction. So when I got the opportunity to hold that probe and learn ultrasound, I was, very excited about it. So that's really what started my sonographer journey.
Right. So tell me really quick tell the populace about your education. So what's your education, Diane? What's your background?
I have a bachelor's degree in, I think it's biology and economics.
You think it's biology?
Well, I ended up changing so many times that
okay.
What did I actually
somewhere in the
end up
biology
with?
realm, BS. Yeah,
and I think psychology is in there also, because I had a concentration with animals, behavior and stuff.
Right. Okay.
And so I had my bachelor's degree and went with that, which got me actually pretty far, because I was at the University of Pittsburgh for a while, and I was able to work with a researcher there. So I got a lot of the science and stats part of doing medicine.
And then you're a certified technician, right?
Yes. I went to school down in North Carolina. I was part of the first graduating class. I have the picture of us all standing with our shovels, because we didn't even have a building yet when we started.
You just keep breaking ground wherever you go.
It was great. We had a couple of great vets who just really pushed and helped us to get all this started in the first year. I was part of the first graduating class.
Great.
I was there on their doorstep.
Great.
Yes.
And now you're SDEP
Yes.
certified sonographer, both abdomen and echo.
Yeah.
Excellent. So Shari, what's your scholastic background?
I went to school for exercise science. I was going to be a gym teacher or something, along those lines. And then I ended up getting married and moving up here, and ended up being on the job trained. And I, sat for the exam and became certified that way, because I was grandfathered in. And I started into the program, and then the program, I guess, originally was all down in Camden, for me, the logistics at that time period and the online options weren't there, so I just continued my education, basically on the job trained, and went to, just took in every course that I could.
I think you were one of the last ones probably to get grandfathered in, right?
Possibly. I think it was
time.
after that there was.
Right.
Yeah, the consortium started up here, because I had gone to Bergen and I went for exercise science, and no one had the program there.
Right. And you're also certified SDEP abdomen and echo.
Yeah.
Great. So I'm gonna bump it over to Ken, just for I have a curiosity, and again, this is real talk, and Ken and I have gone back and forth about. So I grew up mentored by non-certified technicians that could sink a catheter in anything, and so I grew up on that realm in California, where there weren't a ton of certified technicians, but here in the Northeast, everybody. It's almost mandated to be a certified technician at a certain level, and Ken and I go back and forth on that. So Ken, tell me why you insist on certified technicians in your practice before you came on board.
Yeah, that's an interesting question, because for me, as you said, there's a lot of people out there, a lot of great people who have great skills that technicians have to have, like putting a catheter in. There are people who have never gone to school can actually do these catheters. But part of my feeling, and part of what I've been, I guess I always had the mantra of is, it's not just how to do something, and because I can teach somebody how to do things. What's I think harder is to know why you do things. And I think a certified technician, you've gone through a lot of these trainings, So now you know why you're doing it, why you're using a certain vein versus another. And so that's always been a big thing for me, because to me, if people know why things, then they can think through things that go wrong. And so that's always been, for me, that's been a big thing.
Yeah, great. So now this is, how many years we've known each other? 24, 25?
Least, yeah.
We've had this conversation at least double-digit times, and this is the first time you told me actually why you think that. Okay, great. So I have to put you on the spot in front of a camera, in order to get the real truth out of you.
It's important to have standardized training, because you don't know who's going to teach you and where and who, and if you don't go to standardized.
But that's also the thing. I mean, years ago, there weren't very many, and not very many certified technicians. So we had to teach everybody how. And when we were teaching them, my thing was I taught them why as well. Yeah. But then when they have a formalized program, as you guys went through, then it's
Yeah, and even when they come out of those programs, we're still, like I said, you never stop learning. There's always, and like I said, I got very lucky, because where I started, and I was just surrounded by certified technicians who went to school, and so they gave me their literature and their stuff, and they would test me, and just they really, it was really amazing.
Do you find that there's a mentality difference between technicians that are certified and technicians that are not, or is it just a matter of circumstance? And when you see a certified technician, do they have a certain behavior different than a non-certified technician, or is that a globalization?
That's a really good question. As they always say on these things, that's a great question. Wow. I think that, you can't tell by looking at somebody necessarily.
Well, okay, so you see somebody a week you see a well-experienced technician that's not certified in a week in the trenches of a veterinary hospital, from anesthesia to sinking catheters to relations with the pet owners. So take an experienced non-certified technician that and compare it with a certified technician that for 1 week, and kind of create that environment in your head. What's the difference? It stumped you. You didn't think it was going to be this tough this morning, did you?
Yeah, it is a little, because I really have to think about that. I think it depends on the experience of a certified technician. You can't just come out of school.
Sure.
Certain things have to be equivalent, because at some initial point, that experienced non-certified technician is going to be pretty much at the same level
as a well-experienced one, right?
Correct.
Right.
Correct.
That makes sense.
Yeah.
Okay, so take a 5-year experienced CVT versus a 10-year experienced non-CVT.
I still think that what I would see is still knowing the why of things. It's still it depends on the non-certified tech, how far they want to take their education. Like with Shari.
It really depends on the person, because I've worked with CVTs and that come out of school, and of course they're new at it, and I don't, depending on their experience leading up to it, right? Like I've worked with veterinarians and never even had an animal growing up, or never really had a lot of experiences with animals in general, and then I want to be a vet, and that's great. And then everyone's starting out at a different experience level. So I've worked with CVTs that have come out, and they're if don't want to do a lot of things, or just not comfortable, or so it just, they have the education, they have all the whys and the everything, but then they may not be comfortable doing things.
Sure.
So I've seen that. I've worked with that too. Like, no, I don't want to work in surgery. I don't want to do dentals. I don't feel comfortable, or whatever. So I think it just depends on the drive of the person and what they, how they want to see their career path go.
It does come down to a knowledge base. I know I was a non-certified tech assistant for 10 years before I had the opportunity to go to school. And I thought it was going to be really easy, and I pretty much knew everything. Okay, so when I started in that program, by the time I was through, I realized I didn't know half of what I should have known.
It's not knowing what you don't know. Yeah.
Exactly.
Absolutely.
Exactly. I was like, so.
We see that in clinical sonography as well, right?
Yeah.
Not knowing what
For example,
you don't know.
when I went to school, I don't know how the kids learn now, but when we were learning all about doing chemistries, now they have the machines that you don't even have to think. How much do they really know about these machines?
Right.
They don't even do fecal tests anymore. Just send it to the lab.
Sure.
We had to do all of that. We had to do the cytology. When I was in school, we had to actually do each individual chemistry by creating the aliquots.
You got me beat on that
Taking
one.
samples.
I'll go back as far.
Time.
I'll go back as far as dunk
Yeah.
tanks on radiographs, but you got me beat on that one.
Right, exactly, and that kind of teaches us stuff too. But we had to learn that way, which took a long time. But it really taught us exactly how do they get these numbers and what do they mean?
Sure. Yeah, well, I get that.
And I
But
still
now
think
they
of that.
Lose, they
Still
lose
think of
that now too, because if they
All
learn
lost.
to do fecals, now they come into the practices and they're like, well, I learned it in school for 5 minutes and now
Exactly.
I don't
Yeah,
know.
Exactly.
yeah.
And
Or
we
blood
had it.
smears, nobody does
Yeah.
blood
You
smears.
guys
That's-
are really dating yourself.
That's
You
it.
know,
But we can do a blood smear. We
Yeah.
can analyze it.
Absolutely.
We
Well,
can do
cell
we can do a
cytology,
manual
they kept you
diff
with that as
and
well.
back
but-
it up.
Yeah,
What happens
so
if they
they're
have to
both
do a
sides of
manual
it,
diff
right?
because the machine messes up,
machine.
or the doctor says, "Oh, let's can you double check that?"
Right.
We always double checked everyone.
Sure.
Attempt
Well,
to do that.
so they're both sides of the story, right? Because I've seen CVTs come into practice, and my client veterinarian's all excited, I got a CVT and all the rest, and complete disaster of a personality, Whereas
Right.
you get a CVT 5 years out, solid, stayed in the same job, or maybe moved once over a 5-year period and can do everything. Okay, that's what the ideal CVT would be, but how many of those are actually out there, so you get one of those, but
And you know what?
Yeah.
I think we find the same thing with veterinarians.
Oh, absolutely.
Or with any
absolutely.
other.
It's a personality
anybody else
issue.
too.
Sure,
It goes
sure.
down from the top too. In practices that in New Jersey, right? You don't technically have to be certified.
Right.
So if the practice to practice is very different. If you can, and I've been lucky to get into practices that want to give CVTs more responsibility and keep them at that level. So if it undermines the profession a little bit if you go to a practice where they're just hiring people off the street and just showing them how to do it and
Sure.
Right.
letting them do it and letting them call themselves technicians and not assistants.
Well, see, so
know.
I grew up in that though, because I grew up in,
Sure,
and my
absolutely.
veterinary history was in a very rural area in Southern California, and Dee Dee and Carrie, shout out to you. They taught me how to sink catheters the first time, and in anything, to where I could take a dehydrated pancake cat and still drop a catheter without a problem, and so those are skills that are life-saving skills, but they never got certified, at least in the long history with them. They may have afterwards, but and part of that was the leadership of the veterinarian, Dr. Hempel and Dr. Jessup, and they implemented certain criteria within the hospital, very similar to what Ken has done at his place, without having CVT. But there was a regimen. Could they tell you all about the ins and outs of anesthesia? No, but they knew what to do and what was a problem, what a pulse ox was, and all the solid things, which the veterinarian is supposed to be overseeing anyway. But so it's really a certain environmental situation that you can get a great CVT that has a lot of experience, and you can get a disastrous one as well. But and then one that's not a CVT that's as good. Now the next question is, Ken, so if you have a CVT that's 2 years out and it has most of the basic skills down, and you have a technician that can do everything you need that technician to do, that has 5 years experience, do you pay them differently?
Oh.
Real talk. We're at Sonotalks. Real talk.
Absolutely. That's a great question. CVTs, obviously, when they come out, they expect a little bit more because of their education. So, but the same token, if you've got somebody, and there's exceptions to every rule, right? There are non-CVTs that I'd probably put up against almost any CVT, just from experience. But they are, there's exceptions to every rule. So I would think that you pay them based on what the value is in the position. So if that 5 year out can do everything I needed to do, they need to be paid for it. Mm-hmm. And if it's equal to one that has a CVT behind her name, or his name, then so be it. So I don't mind paying someone more than their education indicates.
Okay, cool.
And unfortunately, even your very progressive attitude is what's helped keep the tech profession down to a lower level.
Oh, yeah, real talk coming. All right, like
Honestly,
to see.
it's where we're not where we need to be, where we're not paid what we need to be paid.
Yeah.
It's what has probably kept some extra real extraordinary people out of the profession.
Sure.
You know, New York State at one point opened up grandfathering because so many assistants, I guess, because you're an assistant if you haven't sat for your exam and whatever. But they opened, it was years ago, but New York State opened it up for those who to sit for the exam and grandfather because that their skill level.
And I'm not against non-certified people,
right.
But I'm for all technicians able to get that education that they need and be treated like the professionals that they are.
Sure.
And that has and being able to take them off the street, as the terminology is, has kept the profession behind.
Interesting.
It really
Interesting.
has. I really believe that.
And off the street, they shouldn't be. They should be called assistants,
but they're
and
not.
they should be doing the skill sets that assistants should do. You know,
Well,
because
that falls down under the AVMA's tutelage as far as mandating that, and that gets to be quite dispersive. But I agree with you. I think there should be the structure. There is in human medicine, and we follow so many models from the human side. Even the clinical sonography. It's not done. Sonography is not done by a board of specialists, except on rare occasions in the human side. It's always an RDMS, right? And so, we're using the RDMS model to some extent. We had our last SonoTalks, we talked with Jesse, who's an RDMS and vet assistant combination. There's just, we're trying to follow that model within the parameters of functionality within veterinary medicine.
She even said that her profession changed and got more stringent also, that they needed to do more things, but it's funny how in our profession, and especially in New Jersey, because usually they want to, you to pay for all these little things, and they just sort of like...
So segueing, so we talked about the struggles that you had as technicians and getting street cred essentially, as well as economic cred for what you did as a certified technician. So when the opportunity came to become clinical sonographers, which you did in practice first and then came over as mobile sonographers, and this is all you do now. So what made you make that switch, and what mindset were you in when you made that switch?
I was in a mindset of just feeling somewhat burnt out and kind of bored with what I was doing and not totally happy with what I was doing at that point. I think it's just progression. You stay in something long enough. If you don't end up leaving the profession, any profession, to do something else, you have to progress.
Right.
And I
you had done everything in
progression.
veterinary medicine, small animal. You've done pretty much everything.
Everything I could do other than going to a specialty clinic and expanding at that.
Right.
And everything I could do in a general practice, I think I had done. So I needed something more. Right. Kind of another expansion to kind of another challenge. Right. Or else I might have left if I could have, I know what I would have done. I probably would have gone to ultrasound school. In retrospect, for sure. So that's the choice that I made, was going on and going on to the veterinary.
Right. And Shari,
as much as I could do.
What about you? Yeah, somewhat of a similar bridge.
Well,
over
I mean,
to
I loved
clinical
imaging, so I was thrilled to expand that. And growing up in veterinary medicine, that it didn't seem like that was an opportunity. The doctor came in and did it and did ultrasound, and it just never occurred to me really that I could pursue it in veterinary medicine, really. So I was thrilled to have that opportunity. But for me, I mean, I don't know, it was so much as burnout as much as it took a toll on my back. I mean, just functionality wise, I definitely was down and out on my back quite a bit.
The traditional technician life took it out on your back.
Yeah.
The clinical sonography.
Yeah. So before
it's nice everybody else lifts now, right?
Exactly.
Yeah.
No, definitely. And again, depending on where you were, it's the restraint and that really just took a toll on me, and I think it was a big realization.
I remember plenty of times seeing you with that, wearing that brace around your back.
Yes,
and working,
and I had ice in it.
Working.
Sure.
So I had to always be very careful, and I can just remember this, you know, this big clot hound that came in at 8:30 at night and for a nail trim, and everyone's wrestling it, and I had
the good old $15 wrestle
been
nail trim that
recovering
needs sedation.
from my back, so I was standing there with the clippers, and they're all wrestling this dog, and I'm like, I can't do that.
Good times,
I cannot do that anymore, you know. So, and then it just kind of, you know, it was perfect timing.
Sure.
You know, when Diane had left a year before, I'm like, I cried when she left. I was like, you can't leave me. Don't take me with you.
It actually took you.
Yes.
So
It's just a longer rope to pull you along, you know. So, and that in mind, now that you're clinical sonographers, and you guys scan way better than I do anymore, you know, and it's amazing. It's amazing what you do. As far as image acquisition, it makes our job as specialists easy to interpret. And but that being said, what are the positives and negatives of being a technician, veterinary technician, clinical sonographer? And what advice can you give both veterinarians and other technicians out there if they want to start into image acquisition / clinical sonography? And again, as a technician, we're talking strict image acquisition and compilation of the data to submit to the specialist to interpret. So it is illegal in just about every state that I know for any technician to provide any sort of diagnosis. So I say that out there for the veterinarians, you know, make sure that, you know, you're not caught in that scenario, because it gets really, really sticky regarding, if you like your license, don't let your technician be making any diagnoses of any type or interpretation of a diagnosis. So be very, very careful on that. I've seen some pretty precarious scenarios with it. I just want to segue into that a little bit, just to throw that out there. But again, what's the positive and negatives of being a technician in veterinary medicine that does clinical sonography, and what advice can you give to techs and vets who want to incorporate technician sonography into their practice?
I think the techs have to take the bull by the horns and decide, hey, how can we make an ultrasound program and make it explode? Because you can. I think that there's a problem of lack of thought and planning. You know, they just get an ultrasound machine and a couple of doctors learn how to do it. Maybe they have time to do it, or it just ends up sitting there. But there's no real formal program. And I think a tech who has higher aspirations to make, like, is more embedded in their practice and really wants to help it improve and make something of it and contribute. And what can you do to contribute something major to that practice? Another profit center, another way to help animals keep things in your practice. Start formulating your own plan, and then go to whoever your boss is, the powers that be that make the decisions, and have that plan in place. Who's going to be learning? Who's going to be doing it? Why are they going to be doing it? How do you incorporate the whole practice and get everybody on board, from kennel help to all of the doctors, to receptionists, or the office people? Get everybody on board with supporting that program. And why should technicians be the one doing it and not doctors? Financially, it just makes more sense, because it's to have a doctor do the ultrasounds takes them away from their bigger moneymaker, which is surgery, seeing patients, making the diagnosis.
Very true.
A technician is used to doing the diagnostic part of everything, from doing lab work to x-rays, CT if they've got it. This is just another aspect that they are really trained to do. It's just has a much more in-depth learning curve, and you never ever stop learning. So that's what a person has to realize, and really want to be solving puzzles and continuing to improve when you do it. But I think technicians should be the one doing it in all the hospitals. Yeah.
Well, I'm sure we all know that human medicine is economically driven, right? And so, you know, if they had to pay a boarded radiologist to do every ultrasound, prices are already skyrocketing, and their profit margin would drop significantly as opposed to an RDMS. So RDMSs will make $80 to $120, $130,000 a year, for example, as opposed to a boarded radiologist, it's going to be $400 to $800 plus, in the human field. So just do the math with the time involved, and it makes sense. Well, you take it down to veterinary parameters, and you have a $25 an hour technician doing a 15-minute scan. That's what, $7 an hour, $6 an hour with or $6 a scan, $7 a scan as far as actual employee time. And so as opposed to a doctor getting paid, I don't know, what do doctors get paid an hour? 100, 125, something like that. Yeah, 150, somewhere along those lines. And so you're talking $40, $35, $40 if they're doing 15-minute scans, which there's, if you know what you're doing, you should be doing 15
Easily.
minutes or less and getting everything from the pelvic urethra to common bile duct and so forth, which I sing that song all the time, but it should be 15 minutes or less, and then processing of the case maybe 5 minutes, so 20 minutes a scan, 3 an hour. That should be with the goal, and just economically it makes all sense in the world. Absolutely. Shari, what's your input on that?
Yeah, it makes economic sense, absolutely. I mean, you're gonna, buy a good machine and you're gonna pay it off, but it makes sense just for the animal. I mean, it makes sense medically to know how to ultrasound and have it in practice. It's part of the diagnostics that should be in every practice, like you're doing blood work and doing x-rays in your exam. If it's sick, it should have an ultrasound done. I think that in this day and age, in this time, it's everyone has an ultrasound machine practically in their practice, whether they're just getting cystos, or not, with it, which a lot of them are. You need a good machine, and it's just to be real diagnostic, but it should be in every practice, and we're here to train staff, and the doctors, some of them love to scan also, so if they do love it, economically, yes, they shouldn't, but if they do love to scan, they could incorporate that into their day, but they should have support staff scanning, and it should just be part of your day, part of medicine for the animal.
So that brings up something that, I sing this song all the time, and you guys know it all too well, but you both learned on lesser machines than you're using now, without naming names, and you both have been teaching for a long time. So you've been through the learning curve, and now you're teaching, and you went from a lesser machine to a better machine. So tell me about machine quality in that process.
Well, having gone from the lesser machine, I didn't realize how much of a lesser machine that it was until I scanned on something better. And honestly, as a new sonographer starting out, if you can't see what you're imaging, you're not going to be able to learn very quickly. You're going to have trouble expanding your learning curve from something slow to something fast. Eventually you will learn if you put the time and effort into it, and you can make that lesser machine a better machine. But with the amount of training that we're doing of new people in this day and age, having that better machine right from the get-go is just amazing. In our training labs, you can actually see everything on these great machines that we teach on, and it's going to make your ability in practice to start immediately sending in diagnostic scans, as long as you're following the proper protocol, because things will be there and you can identify them. If you can't see a Duodenal papilla on a lesser machine, whether it's because how much of a lesser machine is that, or plus combined with your inexperience, you're probably not going to be sending that image in. So you're going to be missing some subtle diagnostic pathology.
Yeah, we get that, and I see it on social media a lot. What kind of machine do I get? I'm just getting started, and I don't want to spend a lot. It's contradictory. It's like if you're going to go down, you're going to open that road, bring the paycheck, or bring a paycheck. Bring the credit card. You're going to need to smoke it to do it right, because you're not going to see it, and it just lengthens the curve. You can either have a vertical curve, or you can have a horizontal and slight grade on your curve, or you can have a horizontal and it'll drop off because you get tired of it. You end up spending more time anyway.
I know, because I'm always like,
pay me now or pay me later type of thing.
But no, just go for it. Get the right equipment right from the start, because Technology changes too quickly, so you can't mess around with lesser technology because you're never going to catch up.
Right.
It's just going to.
Well, especially in bigger dogs, right? I mean, you remember
Right.
what you're scanning, scanning a Rottweiler or a Golden Retriever or a big Labrador, which, they have walrus skin, so you have to have something to penetrate it, right? And you guys did that in practice because here in New Jersey, everybody's got Labrador, right? And so remember, tell us about the old machine versus the current machine and a tense Labrador. How does that work?
Yeah.
Can we make the same analogy with purchasing other equipment? Like you wouldn't buy a radiograph machine from 1960, would you?
Right,
I don't know.
course.
I don't know if you can.
Unless you
make that.
really love those dunk tanks.
Right, exactly.
God, I miss those dunk tanks. Ken, do you have any input on this concept?
Yeah, I mean, a number of things. One is, first of all, I mean, these guys are phenomenal. I mean, just listening to them talk, I mean, they're looking for the, duodenal or duodenal papilla. I mean, that's a lot of veterinarians wouldn't even be looking for that. But these guys, that's a routine thing for these guys. And so it's just amazing me how good they are at what they do. But it is, everything you're saying is exactly right. The machines are a big part of it. And, Eric, you know as well as I do, I've been scanning for a long time. My first machine was, the size of a...
It was bigger than you are.
Exactly. And so,
with a mechanical probe, right?
With the mechanical probe. And, looking through the snow on the screen and finding an adrenal, which is why they're so easy today.
That's why we're so good now, because we had such a great imagination back then.
Right.
They say great horses make
so
great
that's all
trainers.
part of looking for
True.
that. Like I said, that's what we do. And the machines make a huge difference. I mean, you guys been around long enough to know that the machines old days versus what you're using today, you can just see things you couldn't before.
And the opportunities for technicians today for ultrasound, it's amazing. When we go into the hospitals and they're always asking and they're wanting, I think because the image is probably so good, but they start picking things out. So I'll start going through the abdomen with them. Oh, what's this? What's that? And then test them, and it's like fun, and they're interested, and they see. I mean, I know it when I started scanning every sick patient, I'm like, I need to put a probe on that. Like you just feel you need to see inside.
Right. And doing clinical sonography, you get to cheat, which is great. You get to scuba dive and get the fish you want for dinner. And you can look at it first instead of hoping you're gonna get it from the boat, right? So along those lines, the last question here, so we can wrap it up. But what is the personality type? And we have our criteria, but your own opinion. What's the personality type of a technician that does well typically along this learning curve of clinical sonography? So if practice owners or practice managers or veterinarians, want to bring, I'm sold on the technician in practice, it's great, but who do I choose? Okay, so we always say, get two. You want two because you want a live probe every time that door's open. So you need two technicians and stagger them to where if you're open 6 days a week, you got a probe viable on the floor 6 days a week, so you need two, and plus two learn better together, right? They can feed off of each other. And so when we do our virtual education with our labs, we suggest that they have two because they can feed off of each other while we're doing the virtual instruction. But aside from that, what type of personality in the vet tech world works for clinical sonography?
Well, I guess a get it done type of person, someone who's going to take the bull by the horns there, Diane mentioned, because it's not easy, okay? If you really do need to put the time in to learn and study and practice, and you need a very supportive, management to, like Diane was saying. So this person really needs to help facilitate that and, take that bull by the horns. That type of person needs to be, very reliable and a self-starter. To take this on, and it's going to be a little bit hard, we show you the trail, but you have to hoof it, like we say, and we're right here with them, and that type of person's going to stick it out and
because
it's a
time allotment,
guess,
right? It's a time
fall in
allotment.
love with it, see the benefit of it. I think they're really seeing the benefit of it every day when we go and we find things in animals that are completely different than what the clinical history looks like. And I think that there's so I think that type of person is driven
Yeah, so talk about the time allotment. So if a technician's barely done cystos, ultrasound guided cystos, and they want to get to a point of doing a complete sonogram, let's talk abdomen only. What type of time frame and time allocation on a daily basis do you think is necessary? Let's say they go and do one of our courses or similar type of program. From that time, from the Monday that they get into the clinic, what are they looking at the next 3 months, the next 6 months?
Yeah, so coming right off the course, I think, you are ready to scan, but you have to do it every day. And it's like basically you've gone through the abdomen quite a few times. You've gone through our training, our videos, but there's a lot of information, right? So the human brain just can't take all this information and put it all together at once. It takes time, right? I mean, just little bits at a time, and everybody learns a little bit differently.
Yeah, those light bulb moments, periodically.
Yeah, I mean, there's definitely, I could even probably find some articles that I've read about that and how the human brain works and putting this all together. And I do take that from, maybe my horse experience and training horses and how they think and how people think. And, there's a lot going on mechanically everywhere, and it just takes time. So you do have to at least give it, I would say the first 3 months, you're going to start feeling a little bit more comfortable. And it's always those adrenals, though. Every patient's a little bit different. So,
yeah, and that also goes back to the machine and the probe that you use in the right position and all that. Because you can flounder if you don't use the right combination. And so then they get frustrated. And so there's nothing worse than, okay, I paid X amount of money to send this technician and this doctor through these courses, and then I bought this $40,000 machine, or in this case we're talking about a lesser machine. So let's say 25 is our budget, right? And you're scanning those, and you're missing adrenals on a Labrador, and somebody gets frustrated. Imagine that scenario, and then boom, nobody wants to touch the machine.
Yeah.
So you have a $25,000-$30,000 paperweight that's getting cystos and fast scans.
Because no one wants to feel like they can't do it, or they can't find it, or they feel lesser, like, why can't I do this? And it's normal. And we tell everyone all the time, it's very normal. You're going to have a really great day, and then you're going to get set back, like, I can't do this, I can't find anything, and you just got to push through.
Right. Well, plus the other thing is they don't know what they're not seeing, and so, but that's why you have the image capture to where we can see it. I mean, it's like, I don't see the adrenal, I'll get that in the history. I don't see the adrenal, no matter whether it's a technician or a doctor, whatever. I don't see the adrenal, and they're doing the right approach, and they're sweeping the right kidney to the vena cava. It's like, yeah, it's right there, boom, it's on the, it's like,
We've made it easy, right?
Yeah,
We've made it easy as you possibly could be with the
Yeah.
protocol. So if you follow the protocol and you find your landmarks, and you're sending that in where, you're going to read your reports, and you're going to look at those images, and that's going to be part of the learning process to, you just 6 months. I mean, if it, at least, like, just a good 6 months.
You need to lock them in. They have to have a mental lock and focus.
You have to be very committed.
Yeah, laser focus for 6 months.
I got to say, none of this is going to happen if it doesn't start with before the training, when you decide, hey, I'm going to send these people for training.
Right.
3 months ahead, 6 months, however long you have before you go for your training, you got to have the support of that hospital and everybody. Or when you come back, I have seen these techs flounder. I've seen doctors not have the time to scan. Their skills just go off. They spend all this money. I've seen techs flounder because the doctor doesn't have the trust in them to say, go ahead and send this scan in. You got to practice first. Well, you can't practice at home. You can't practice in the clinic and not send something in.
Yeah.
How do you know you're practicing right?
Yeah.
You have to have that. Is it going to be established that you're going to have the support before you ever come back on Monday morning and start?
Right. They don't know what they're getting, right?
They
don't know they're getting their adrenals because they don't see them, but we see them. Plus, the little secret of telemedicine is the DICOM images have an inherent higher quality than you're actually seeing on your ultrasound screen, because the screen resolution is like 1280 in most machines and 1980 in ours. But when you put it in front of a retinal display on a Mac, it jumps much better than it does on the ultrasound machine.
That's why we're so good.
Exactly. So it's like, wait a minute, that's not the adrenal that I saw. That adrenal on that report, I didn't see that. Of course you didn't, because the inherent resolution within the DICOM file is only as good as the screen and the computer you're putting it in, right? So we put it in, put it in our DICOM reader and on a Retina display, high resolution, and it's like, we see it, and it's like, great, but they don't see it scanning. I mean, I've even seen my own images that I've put on. It's like, wow, I didn't see that adrenal that well on site, and then I see it in my computer, and it's a totally different ballgame. So you got to realize that what's in the hard drive is much better than what's on the screen, and people forget that, and so if you don't see it, doesn't mean it's not there. You just have to get the image through the structure, right? And so the specialist can see it.
Yeah.
So
But
and
part
that's
of the
that kind of
learning is
crosses
they have
that
to go
bridge,
back and read
shortens
your
that bridge.
reports, and when you're pointing like, hey, this is the adrenal, they and I've gone on Zoom calls with our clients many different times, and I've brought those videos back up where and so it's really important to go back through your scan and look at those, read the report and look at the images. He's talking to you through the report, really. He's pointing it out to you. So you need to go back and look at that. And, when you were training me, like, it's right there, like, get the phone. I'm like, where? I didn't see anything. What are you talking about?
Look for the arrowhead.
It really
look for the arrowhead.
takes some time to just give, the person needs to just give themselves a break.
Right.
And make
people
that
are hard on
commitment.
themselves, especially the
Very.
mentality that we're talking about, right?
Well,
Those
yeah.
are the
That's what
people
you
that really beat
But
themselves
it
up,
needs to come
right?
from the top.
Sure.
It needs to come from management, really, in the
Yeah.
end. Because if they took the commitment to come to lab and get to that point and go back home to their practices, you have to scan. You have to. You can't, like anything, if you're learning any physical activity, that muscle memory and putting that all together, it takes time, little bits at a time, and you have to scan. And we got lucky, in our practice, and Monday morning was like, I have a scan for you, and I'm like,
Really?
okay.
What? Wait.
Well, you guys had a
didn't have a
clinical
choice.
sonography posse
We didn't have a
in
choice.
your clinic.
But I didn't have
every
a choice
clinic
to be
needs
like,
a
I'm not
posse,
ready,
right?
I gotta practice.
You need that
Well,
doctor that's going to
practicing.
support. You need the other technician, the doctor, the management, the two technicians. Need that rectangle of support within the clinic, and then just let the results play out.
And then when teaching our new tech, I said, what's the worst case scenario? The worst case scenario, you missed it, you have to do it again, the client has to come back. Like, seriously, like literally, that's really probably the worst case scenario, is that you missed something and we need more images.
Sure.
And if you're local, we could come help you. If not, we were right here to help you and everyone to do that. And I think that alleviates some stress. Like, okay, so what's the worst thing? Dog needs to come back.
Right.
We'll get the images.
Absolutely.
It's okay.
Had one of those, they were doing a repro check, which I just love repro. But, they're looking for the ovaries, and we talked them through how to get the ovaries. They got the ovaries perfectly, but they couldn't see them, but we could see them.
Right.
It's like, here it is,
Yeah, it takes time to differentiate everything. So.
Ken, do you have any input on this? What's the technician that works best in your experience?
Well, I definitely, with everything they've been saying, and the whole reality is that you've got to get that block of time for them to learn. And, essentially you're paying them to learn, but the rewards you get back from that are, astronomical. But that's got to be a commitment on that person. And there are people who said, you know what, I really want to do ultrasound. So we send them to the course, they do it, and then they go through it all, and then they start practicing, and they say, you know what, I don't really love this, like I thought I would. And that's okay. But at least they know, okay, it's not worth putting their time into because they don't want to do it anymore. Right. But if you really love it, it takes time. And as I say, 6 months, you've got to, everyone in the hospital has to be on board, as both these guys have indicated that. If not, then you're fighting two things. One is the learning curve, and the people that are you're trying to do the scans for.
Right.
Yeah, we have seen technicians that seem to really love it and come off our course, and I'm like, why are you scanning? Why don't we have time or shorthanded? Like, so the commitment on the management end, they wanted to do it, but the commitment on the management end, and I get it. They need the technician, and I would give them ideas. Well, maybe the dog could just be sedated for you, and then that way.
Sedate. Yeah, early scans make it easy on you and sedate, because it takes those extra sets of hands out of there and allows you to take your time and implement the protocol sedate, especially early on the curve.
Scan everything you can, and
So-
anything and everything that's sick, and just make that commitment, because it's the only way to learn. It's the only way.
Yeah, it's definitely a forest versus a tree concept, right? So if you're going to go down clinical sonography and practice, you have to think of the forest. You have to think of the 6 month, the 12 month, what's the forest going to look like in the next 2 years? Done right, it's an astronomical improvement of diagnostic efficiency in your practice, and that breeds business, because everybody talks. Your grade A clients talk to their grade A clients. So if they have a great conversation, then you're going to get more grade A clients through your practice. Oh yeah, Fido had, they found out he had a perforating gallbladder mucocele 4 days in, and I already spent all the money that I had. Where you put a probe on that day one,
That's
boom,
best
you're off to
medicine.
surgery, and you're on top of it. They're gonna, the second scenario is what you want them talking about. Having 2 technicians in practice putting a probe on everything that's sick is, done
It's
right.
definitely best medicine.
But they need the posse there, in the ultrasound posse in the clinic, from who's paying for the process, who's directing the process, who is prescribing the process, and who is actively doing the process. They have to have those 4 things. If they don't, then it's going to be a waste of everybody's time and money.
And then the machine sits there.
And the machine sits
And
there.
then
absolutely.
technology just
Yeah.
keeps going.
And then technology and the machines depreciate 10 grand a year. So, you pay 40 grand, 45 grand for a machine, in 5 years, it's, worth $5,000 or $7,000 or $8,000, because the whole, it's like taking a car off the lot. When you buy a new car, you take it off the lot, but it drops 20% in value. And
in this area,
it's the same sort of thing.
we're lucky that we're here on the road. We're here supporting everyone on the road, but in maybe remote areas that, maybe there's no, services for people. I think, in a way, it's kind of a responsibility. I
Sure.
mean, it's
Sure.
to know how to function with the probe a little bit. If I were a veterinarian, and especially, I think that it's almost, how do you function without that,
Sure.
without at least knowing, is it the heart, is it the abdomen, what's going on, this animal's not right, so I think it's just really a part of practice now.
Well, great.
Or
Well,
should be, anyway.
I personally can say, and I know I can speak for Ken as well, that we're really proud of your journey, your guys' journey. Since I've known Diane, I've known you for 20 years now, and something like that. Yeah, and Shari for 15, and watched your journey, and I'm still so glad you guys are still in veterinary medicine. I think clinical sonography is a big part of that. And you guys do a great service, and hopefully many of the people listening will, whether they're technicians or practitioners that have technicians or office managers or whoever you are out there, do the process right, and it's a great thing for the industry. It's a great thing for your practice or your multiple practices. So great. Well, thanks for joining us today, guys, and have a wonderful day. I know you got to put the probe on some animals today, so we'll let you go and do that. Thanks, everybody. Looking forward to talking to you the next time on SonoPath Podcast. Real talk in veterinary medicine. Take care, everybody.